All right, let's do this. We are about to do a rapid-fire, super high-yield blitz through the elbow and forearm. This is literally everything you need to know and nothing you don't to absolutely crush your board exams. Let's jump right in. So what on earth does breaking a pretzel have to do with you acing your ortho questions? I know, it sounds a little weird, but this one simple analogy, it is the key to unlocking some of the most commonly tested forearm injuries. So stick with me here. I promise it's going to make everything click.
And that brings us to the core concept for this entire review, the forearm pretzel principle. Seriously, if you can get your head around this one mechanical idea, you're going to be able to reason your way through these complex fracture patterns without having to just memorize a ton of isolated facts.
So here's how it works. I want you to think of the radius and the ulna and how they're connected by that interosseous membrane and the joints at the wrist and elbow. They form a single closed ring. Now, just like a pretzel, if you try to break it, it's almost impossible to get it to snap in just one spot. It pretty much always breaks in two. Okay, so this is the crucial point for your exam. If a question shows you what looks like an isolated fracture of the radius or the ulna, it's a trap. There has to be a second injury, another fracture or a dislocation somewhere else. Your job, and the whole point of those what's the next step questions, is to know exactly where to look for it. So let's see how this whole pretzel principle plays out in the real world. It's perfectly illustrated by a few high-yield, eponymous name fractures that examiners absolutely love to test you on.
This chart lays it all out. We've got three key players here. First, Monteggia. That's a proximal ulna fracture paired with a radial head dislocation. Then there's Galeazzi, a distal radius fracture paired with a dislocation of the distal radial ulnar joint, or the DRUJ. And finally, Essex-Lopresti, a radial head fracture that also blows out the DRUJ. See the pattern? It's always a fracture plus a dislocation.
Now, to keep those first two straight, you have got to burn this into your memory. MUGR. MUGR. Monteggia involves the ulna. Galeazzi involves the radius. It's a simple, totally foolproof way to get the question right every single time. Don't miss those points. All right, let's hit some quick testable trivia. Remember Monteggia for minors because it's way more common in kids. For Galeazzi, just picture that classic distal radius fracture with the DRUJ blown out. But for Essex-Lopresti, the key word you have to remember is unstable. This is the bad one. This is where force travels right up the arm, fractures the radial head, blows out the DRUJ, and, this is critical, tears the interosseous membrane that holds that whole pretzel together. Okay, let's shift gears. We're moving away from acute fractures and into injuries from repetitive stress and instability. This stuff is huge for sports medicine questions, so you're going to want to pay close attention here. So here we're looking at two totally different ways to get an unstable elbow. On one side, you've got valgus overload. This is that chronic, repetitive stress injury from something like throwing. Think of a baseball pitcher. The force puts tension on the inside of the elbow and compression on the outside, really stressing that ulnar collateral ligament. Then on the other side, you've got the Essex-Lopresti. That's an acute, high-energy injury from a fall, where the force shoots straight up the arm and just ruptures that interosseous membrane. When you see thrower's elbow or valgus overload on an exam, your brain needs to immediately flash to this classic triad. Number one, tension on the medial side injures the UCL, and you got to remember the anterior bundle is the key part. Number two, compression on the lateral side can cause an osteochondral defect or an OCD at the capitellum. And number three, you get posterior shear forces that lead to bone spurs or osteophyte formation. You have to love this quote from the source material, right? This is little leaguer elbow in a nutshell. It's basically the pediatric version of valgus overload. It's a chronic stress injury, maybe an avulsion of that medial epicondyle from, too much throwing too soon.
Now for a classic nerve entrapment, cubital tunnel syndrome. This is just compression of the ulnar nerve right there at the elbow. For your test, you need to know the specific anatomical structures that can cause this. The two big ones they love to ask about are Osborne's ligament, which kind of forms the roof of the tunnel, and this pesky little anatomical variant called an accessory Anconeus muscle, which can create a mass effect and squish the nerve.
Let's move on to the common tendinopathies of the elbow. The itises and the osis. The absolute easiest way to remember these is to just think of them as opposites. One is from extension, the other from flexion. This slide just makes it so simple. Lateral epicondylitis, which we all know as tennis elbow, is way more common. It's caused by repetitive wrist extension, and the tendon that's usually the bad guy is the extensor carpi radialis brevis.
Medial epicondylitis, or golfer's elbow, is the exact opposite. It's from repetitive wrist flexion and involves the common flexor tendon. Just remember, extension versus flexion, that's the whole game.
All right, let's tackle two injuries that have these really distinct visual and clinical presentations, which, of course, make for great exam questions. Elbow instability and a torn biceps.
So, elbow dislocations don't just happen randomly. They actually follow this very predictable pattern called posterolateral rotary instability. It always starts on the lateral side, with a tear of the lateral ulnar collateral ligament. That's stage 1. As the instability gets worse, the joint starts to open up until the coronoid is just barely hanging on or perched on the trochlea. That's stage 2. And then finally, with a little more force, you get a complete dislocation in stage 3. It's a cascade, always moving from lateral to medial.
And here's the classic biceps tear. The question might describe a weightlifter using that over-under grip during a deadlift. The patient feels a pop and now has this painful lump in the front of their elbow. Well, that balled-up, retracted muscle, that's the Popeye deformity. And here's a little pro tip for your exam. Always consider associated median nerve symptoms with a biceps injury.
To wrap things up, we have to talk about radiographs. Honestly, recognizing these subtle little signs is often the difference between getting a question right or wrong.
You will almost certainly see the sale sign on your test. All it is a joint effusion, blood or fluid in the joint, that pushes the normal fat pads away from the bone, making them visible on an X-ray. When you see this, you have to suspect an occult or hidden fracture, even if you can't see the fracture line itself. And the most common culprit? A non-displaced radial head fracture.
So let's break down how to actually interpret these fat pads. An anterior fat pad, well, you can sometimes see a little one normally, but a posterior fat pad, you should never be able to see that on a true lateral X-ray. So if you see the posterior fat pad at all, that's a positive sign for fluid in the joint. That is the key takeaway. But remember, this all depends on good positioning. If the elbow isn't flexed to 90 degrees, you might get a false positive.
And here they are, 3 last-minute must-know facts for test day. The most common elbow fracture in adults is the radial head. For kids, it's the supracondylar fracture. And if you ever see a fracture of the capitellum, you should have a super high suspicion for an associated posterior elbow dislocation. So let's end with this. A question gives you an X-ray, and it looks like a simple, isolated fracture of the ulna. Based on everything we've just talked about, what is your next step? What are you thinking? Remember the pretzel. It never breaks in just one place. You have to find that second injury.